For next session, we're going to have two talks. The first one by Dr. Rula Hajj-Ali. She's a staff physician at the Center for Vasculitis Care and Research at our Cleveland Clinic and has many, many years, a tremendous amount of experience with central nervous system vasculitis, and will share this experience that she has a little bit with us today. Thank you.
Thank you so much, Alex, for the introduction. Good morning, everyone. So when Carol asked me to put this presentation together, I thought we'll talk about approach of patients suspected to have CNS vasculitis. We'll take some case vignettes and talk about the treatment and outcome in these patients. So although CNS vasculitis is rare, but you're going to be asked to give your input in many, many occasions because this scenario comes up very often. And you will be asked to give your opinion in a patient with unexplained neurologic deficit, or more commonly in a patient who presents with recurrent or even initial stroke, in a patient who have no vascular risk factors to explain the strokes, or in the same setting when a workup of patient with stroke, when you have an abnormal cerebrovascular imaging, your input will be requested to assess if the patient has an inflammatory etiology of these abnormalities. And from a different perspective, you will be also asked to give an input on a patient who's being worked up and found out to have a neuroinflammatory process, and to assess whether this is in the brain solo, and to give your opinion if this is a vasculitic in nature, as well as whether there is more systemic inflammation, or also in our diseases where, inflammatory diseases that we follow, and in a patient who comes in with a neurologic deficit. So as you see, there are multiple different scenarios that you will be, asked to give your opinion, although you may end up having a low number of patients diagnosed with CNS vasculitis. But what I am hoping to get also share with you today is some of the approach that we do in trying to give you a better evaluation on how we dissect this. So CNS vasculitis has multiple challenges. That's sometimes being primary, where the inflammation is only in the brain or the spinal cord. And by being so, your approach and your diagnostic approach is going to be tailored towards only the brain and the spine, which is really very hard because the tissue is somehow inaccessible, most of the time. But at the same time, it also can present as a secondary process to either an inflammatory conditions or even an infectious process. So you end up looking for systemic inflammatory, systemic infectious processes at the same time. And to add to the challenges is that the clinical features are not very specific. And if you look at the clinical features of CNS vasculitis, as you see here, most commonly patients present with chronic insidious headaches, plus or minus neurologic deficits such as encephalopathy, behavioral changes, hemiparesis, focal motor abnormalities, etc. But as you see, these are not very specific at all. And just by looking at the clinical manifestation by itself is not going to help you diagnose CNS vasculitis, although there are some pretest probability higher pretest probability with clinical manifestation in a patient who present with chronic meningitis-like picture with no infection found, as well as a focal deficit. So the way we look at CNS vasculitis, there's three main key elements in the diagnostic approach. And I always ask ourselves when we are, assessing a patient, and wherever, if there is an if there is a stroke or any neurologic deficit or abnormal vascular imaging, we always ask ourselves how we can demonstrate if there is a neuroinflammatory process going on. You really have to demonstrate there is inflammation there in the brain. And second, you're going to assess if the inflammatory state is limited to the CNS or there are other organ involvement. And that includes, ruling out the mimics. So these are when, I zoom out and I look at, 360 picture. These are the three main questions that I look into when we are assessing patient with CNS vasculitis. And one of the many contributions that Len Calabrese have in this domain is proposing the diagnostic criteria. And what did Len taught us is that to really make a diagnosis of CNS vasculitis, you have to prove that there is some inflammatory process in the vessel, whether directly by biopsy of the brain or indirectly by abnormal cerebral vascular imaging. But the most important that he put in the criteria is to rule other mimics, even mimics that can cause abnormal cerebrovascular imaging and also, can cause abnormal pathologic finding like vasculitis, which can happen in infection, can happen also in malignancy. So these criteria remain the basis of our diagnostic workup in CNS vasculitis. And I'll share with you how we can demonstrate there is a neuroinflammatory process in the brain. And your CSF is really, really important, and you should not omit an LP to get CSF unless there is a contraindication to do so. And your CSF is a very accessible fluid that can reflect so much changes in the brain. It's really a very good a surrogate marker of what's going on in the brain, as much as you could do with non-invasive way. And with the CSF, you look if there is an inflammatory process or non-inflammatory process. When I say inflammatory process, you look for pleocytosis and increased protein. And from our data, we found out that higher pleocytosis is more specific than, for inflammation than elevated protein, because elevated protein in the CSF can be also present from non-inflammatory process, such as in patient with diabetes, in patient with severe stenosis, and other factors can have elevated protein. So per se, just elevated protein may not be very specific for inflammation. So that's first thing, you demonstrated if there's inflammation or not. Second, you're going to rule out infection and an inflammatory process. And, at minimum, you're getting your routine culture. In addition, we look for Lyme disease, TB, syphilis. You'll be very surprised how many neurosyphilis we see. TB, VZV, acute encephalitis panel, and most of our institutions also have access to send out universal PCR for if you're still suspecting, infection. And also, we have the ability to send out next generation sequence, which you have a ability to sequence your CSF and look for non-host sequences. These are in patients with inflammatory CSF when you are still looking for infection. And, all the CSF infectious workup is also tailored on exposure of the patients. But in vasculitis, the sensitivity of the CSF being inflammatory varies depending on the type of the vasculitis. If you have a localized type of vasculitis in the brain, your CSF may not be sensitive. But in the small vessel vasculitis, where you have diffuse inflammation, up to 95% sensitivity. Other diagnostic modality are the non-vascular neuroimaging, and what I mean by that is your CT scan and your MRI. Your MRI is more sensitive than your CT, and what you see, but it's not very specific. And Dr. Kiczek will go over this in the next session. But what you could see is, I think I have a. What you could see is very non-specific features where you have multiple strokes, which could be from embolic diseases. You have a mass-like presentation, and this could be a tumor or cancer, but that's, by biopsy. So the MRI findings are not very specific. They're not going to tell you there's inflammation or not. However, the non-vascular imaging is highly sensitive and does carry a very high negative predictive value. So I've never seen a patient with CNS vasculitis with a normal MRI of the brain. keep that in mind. So if you have a normal MRI of a brain, normal CSF, less likely the patient has CNS vasculitis. Talking about vascular imaging in CNS vasculitis, there's direct and indirect. I'm not going to go into detail. You'll hear from the expert, Dr. Kiczek. I'm just going to, if you want to get one message from me on this slide is that there is no angiographic study of 100% specificity for the diagnosis of CNS vasculitis. Where you see multiple area or diagnosis of stenosis and dilatation, this is not specific for vasculitis. Does not mean there is inflammation. You really have to complement your workup. If you see an abnormal angiogram or abnormal MRA, that there is inflammation there. This is not a 100% that you have an inflammation there. And the sensitivity also is low, that even an angiogram, which has a higher resolution among all the vascular imaging, can be negative in patients who have very small vessel vasculitis. So a negative angiogram does not rule out a vasculitis, and a positive cerebrovascular imaging does not mean the patient have vasculitis. This is a patient with RCVS, where you see multiple area of dilatation and stenosis in multiple beds, and this is a vasospasm. This is not a vasculitis. And the other imaging that we incorporate, and you're going to hear more about this in the second session, is the vessel wall imaging. And in the vessel wall imaging, we look at the vessel wall enhancement itself. And these are images from a patient with CNS vasculitis who does have different stages. In the upper slide, the initial stage of CNS vasculitis, and in the middle one, where you see this concentric involvement and enhancement of the vessel wall all along, and then resolution of that in the last slide. It will be nice to have this clear in every single patient, but doesn't happen. This is a complementary, if you want to say, imaging to whatever you have. Not everything that enhances is vasculitis. You can have enhancement in atherosclerosis, and you can have, most of the time we have a mixed picture, and it's very hard to know. So this is not going to be a diagnostic procedure for patients with CNS vasculitis. This is another way to look if there is inflammation, and you have to put everything together. The gold standard to really demonstrate if there is inflammation is getting a biopsy. And the biopsy is the gold standard. However, it is not 100% sensitive. Sensitivity is up to 70% of the cases. But when your non-invasive way of getting a biopsy did not reach a diagnosis, you really want to get a biopsy. And I'll share you a case that we just recently saw in the hospital, that the biopsy really was informative. And even if your biopsy may not show, in about 40% of the cases, it's going to show you a different diagnosis. But what is a positive brain biopsy? Positive brain biopsy for vasculitis is a true vasculitis, which is inflammation in the whole vessel wall. Perivascular inflammation occur in multiple insults in the brain. So if you have hypoxia or infection or even vasculitis, you can have perivascular inflammation, but it's not very specific. The reason I'm putting this up here is because if you have a patient that you treated for CNS vasculitis based on a perivascular inflammation, and they don't do well, revisit the diagnosis. Diagnosis may be different. And always when you have an a pathology, make sure you rule out the mimics, such as an infection. Make sure you stain for amyloid angiopathy, especially in patients who have granulomatous angiitis and in the elderly. And in patients who have lymphocytic inflammation in the brain, make sure that you talk to the pathologist to make sure they rule out lymphocytic lymphoma. So the second key element in the diagnostic approach is really if you have demonstrated there is inflammation in the brain, you want to know if there is inflammation just in the brain or somewhere else. And the audience here is so tuned to do that, and you guys do that very well every single day. But the way I remind myself always is about two things. Is always remind myself about asking for family history of neurologic diseases. And there are so many genetic diseases that occurs, and the more we know about genetic disease, I think more common than we think, and there are diagnosed. So when we see patients who have been diagnosed with possible CNS vasculitis, treated as such, as we saw a patient recently who was referred to us, and they don't do well, always ask about if there's any neurologic things in the family. Is there any family member who died early? Anybody who have brain tumors or MS-like pictures or retinal involvement? We just recently diagnosed a patient with TREX1 mutation, which is an autosomal dominant disease that affects the brain, present in about in the age of 40s, and they present with mass-like presentation or enhancing lesion. And the biopsy shows necrotizing necrosis. It's not really vasculitis, but necrosis. But you could say, this could be probably they missed something on the biopsy. It's a small tissue, and patient was treated with multiple courses for a good regimen for CNS vasculitis, but they don't do well. They did not do well. And they had subtle abnormalities such as rheumatology and kidney disease. We ended up doing genetic testing for TREX1 mutation, and the patient had TREX1 mutation. Other thing that I remind myself all the time is to ask for exposure, recent travels, immune status of the host, to really tailor my approach to whether I really want to focus more on infection. And I may not check cysticercosis on every single patient, but if a patient, have a recurrent travel to endemic area, I may include that in my workup. So that, it takes a multidisciplinary approach to look at mimics and exclusion of the disease. You guys are the best team to look for inflammatory conditions. Your neurologists, your infectious disease colleagues are really very important. Your neuroradiologists as well. And your neurologist can assess for thromboembolic disease, atherosclerotic disease, autoimmune encephalitis-like picture. Your neuroradiologist, I am very, really have a great opportunity to have a talented team here in neuroradiology and infectious disease and neurologists who help us into, these patients, where everybody has to look this from a different perspective. And there are some miscellaneous that you have to keep in mind, such as I said, genetic diseases, and you raise this in patients who don't do well with typical treatment. And genetic diseases such as CADASIL, TREX1 mutation, CADASIL, and DADA2, and also in patients with SUSAC syndrome, especially in patients with female who present with, young female with encephalopathic changes, always look for SUSAC. And the way to do so is by looking for fluorescent angiograms. These patients are encephalopathic, and they may not share with you that they have vision changes because they cannot, but you can get a diagnosis of SUSAC by just looking at fluorescent angiogram in such a setting. So let's move a little bit to share a quick case. This is a 66-year-old with Crohn's disease with multiple strokes, presented in July with stroke, treated with regular stroke treatment, aspirin and lipid lowering. And he kept having issues. They thought that this could be from Crohn's, just generalized symptoms, and vedolizumab was started. And then in December, was found to have a new infarct. So they started high dose of prednisone, thinking that, he probably have this infarct because of the Crohn's, and Crohn's can sometimes has vasculitis, or, this is because of an inflammatory state. So it was treated with high dose of steroid. He kept having more deficits, and he presented to our hospital in March with further decline in neurologic status, and the MRI showed multifocal subacute infarct and acute infarct across multiple vascular territories. So the first thing they started to rule out embolic, had multiple echoes and telemetry that did not show any evidence of thromboembolic disease. Patient also have 20 to 25 weight loss. And he was really nonverbal, not oriented, nothing else on the physical exam. And if you look at his peripheral blood test was negative for hypercoagulable disease, ANA, ANCA, everything was negative. The main thing was because he was immunosuppressed, there was a very thorough infectious workup performed and was negative. And looking at the CSF, we have high protein, no cells, glucose was normal, which is reassuring that this is probably not infection, but in addition to that, there was multiple infectious workup was negative. And this is his MRIs that shows multiple area of infarction, and on the I don't know if I can see the pointer, but there's multiple area on his vascular imaging, the angiogram of area of stenotic and dilatation area in multiple vascular bed. So the question, that was posed to the team is this CNS vasculitis? If this is a patient with Crohn's, can sometimes cause vasculitis, and you have vascular imaging that shows possible to have vascular involvement and the CSF abnormal. But because the patient was on a high dose of steroid for many weeks, 2 months, and this already happens through that, the question was, this probably something else. And the team asked for a biopsy, which showed intravascular lymphoma. So it was, at the point of the decision was really very hard, and I wasn't part of that diagnostic decision, but the team did a great job with that. This is another patient who presented with minimal vascular risk factor with recurrent stroke. He admitted to have cocaine, but not recent IV use, and as well as marijuana. Just for vascular risk factors, he smokes. Multiple area of infarction. You can see on the angiogram, very severe stenotic area, and the vessel wall enhancement where the arrows are, you see this concentric enhancement in multiple vessel area, and especially in the midbrain area. So his diagnostic workup showed that his CSF was inflammatory, mildly low glucose, but his blood glucose was also low, and he had an extensive CSF for infection was negative and no growth. So because the lesion was too risky to biopsy, and the working diagnosis was inflammatory CNS vasculitis, negative infection workup, the team decided to treat him with steroid and was discharged on oral prednisone, but he did worse and he came back, and another CSF showed worsening of his white count at the same time. When he came in, his CSF aspergillosis came back positive. So failure to respond to treatment really should raise a big flag for another etiology. What I see most commonly in my referrals, things that mimic CNS vasculitis are atherosclerotic arterioembolic diseases, especially with premature atherosclerotic disease. So differentiating factors with that, in atherosclerotic disease at the time of acute stroke, you actually can see a little bit of pleocytosis and high protein. So be careful with that. But your vessel wall imaging is going to help you here. You can see a plaque in your CTA, in RCVS, which is a vasospastic condition in the brain, present mainly with young female with acute thunderclap headache. Your CSF is normal. Your vessel wall imaging is does not show enhancement, but you have this diffuse abnormality in the angiogram. Your infectious CNS vasculitis could be, the same as CNS vasculitis. And intravascular lymphoma, as I show you in this patient, sometimes the first biopsy is actually looking lymphocytic with normal cells, but then patients don't do well. We had several patients who had a second biopsy to have a diagnosis. CNS vasculitis in systemic diseases in SLE is extremely rare. Neuro lupus is not the same as CNS vasculitis. It's mainly affecting the parenchyma, not the vessels. CNS vasculitis can occur really in sarcoidosis, mixed connective disease, Sjogren. CNS involvement in ANCA-associated vasculitis is about 33% of the cases. Stroke are uncommon in GCA, and if they occur secondary to vertebrobasal artery involvement. Intracranial involvement of GCA is controversial. And Takayasu arteritis causing stroke. especially in young women, should be a consideration, but also is because of extracranial involvement and the carotid involvement. Other systemic diseases included PsA, and that can occur in parenchymal and non-parenchymal disease. Also, to raise your attention to another systemic disease that can cause CNS vasculitis is CVID. A patient presents with brain mass-like lesion and leptomeningeal enhancement. You have to rule out infection giving their CVID. This is a patient of ours who had a biopsy of the brain and showed severe vasculitis in one of the vessels and was treated with rituximab. ADA2 deficiency, which is an autosomal recessive disease, can present with stroke, usually in young, but sometimes a patient can remain asymptomatic through adulthood. All right, I'm going to finish up with treatment outcome. There are multiple gaps in the management of CNS vasculitis, and sometimes we are really pushed to have a treatment, although we have uncertainty in the diagnosis, even the best effort of our diagnostic workup. And the treatment strategy is based on case series, retrospective study, and expert opinion. And there's still big need for classification criteria, diagnostic recommendation, and subcategory, and as well as disease activity rules and their tools. And there's a big international effort that is headed by our center to actually look at this gap in CNS vasculitis. This is the general scheme of treatment of patients with CNS vasculitis. If you diagnose patient, whether it's possible or definitive with CNS vasculitis, and you put them into induction therapy, if they don't do well, revisit the diagnosis. This could be something else. If they do well, induce them for like 6 months. And then maintain them on some kind of maintenance therapy because this actually relapse. The consensus is to use glucocorticoid as the first-line agent, and the selection of secondary agent depends on the burden of the disease, the degree of neurologic deficit, the certainty of the diagnosis, and the pathologic pattern. If you look at the Mayo Clinic series that has the larger number of patients with pathology, what they have reported worst outcome in patients with necrotizing granulomatous and amyloid-related angiitis. So these are the patients that you have to, induce them aggressively with cyclophosphamide. Patients with lymphocytic pathology did not have a worse prognosis. So when you see granulomatous angiitis, necrotizing vasculitis, treat with, in addition to your glucocorticoid, treat with cyclophosphamide. We usually induce our patients with 6 months of cyclophosphamide, then we transition them to maintenance therapy. There are roles for mycophenolate in this disease, and this is when you have mild disease with non-necrotizing, non-granulomatous pattern, and with a probable diagnosis with no high diagnostic confidence, and when cyclophosphamide is not plausible. Rituximab in CNS vasculitis is not the first-line treatment, and there's only anecdotal use in this condition, and we don't recommend it as a first-line therapy. But in CVID, we have used anecdotally rituximab with a good response. We use anti-TNF in ADA2. There is some data on that, as well as anti-TNF in neurologic involvement in PsA. You maintain your patients with mainly azathioprine, mycophenolate. Methotrexate does not penetrate well the CNS, and rarely rituximab, infliximab, and leflunomide. And again, this should not be a first-line therapy. So in summary, diagnosis should be made after thorough evaluation to rule out mimics. CSF are the key element in the diagnostic workup. Cerebrovascular studies lack a high specificity in the diagnosis, and the cerebral biopsies are underutilized and should be highly considered if non-invasive workup is non-revealing. No proven therapy for CNS vasculitis based on high-grade scientific evidence. High-dose glucocorticoids are the mainstay of treatment, and cyclophosphamide should be the induction agent in granulomatous angiitis and necrotizing vasculitis pattern. And maintenance therapy is recommended, and mainly with mycophenolate and azathioprine. And, rituximab is not the first-line treatment at this time. and validated classification criteria as well as recommendation for treatment and diagnosis are really highly needed, and our center is leading this as an international effort. Thank you so much for listening, and I'll stop here.
The next speaker on the same topic of CNS vasculitis is a colleague of Dr. Hajj-Ali, Dr. Matthew Kiczek, who is a neuroradiologist here at the Cleveland Clinic with a lot of experience on CNS vasculitis and also a part of the CNS multidisciplinary vasculitis clinic that is carried here at the Cleveland Clinic. Dr. Kiczek.
Hi, thanks so much. Good morning. I'm happy to be here to talk about the radiographic evaluation of CNS vasculitis. So I'm Matthew Kiczek. I'm one of the neuroradiologists here at the Cleveland Clinic, and I'm going to show a lot of images because I'm a radiologist, so hopefully that's something you guys like to see. So what are the goals of this talk? So what will we touch on today? We'll see initial approach to the radiographic investigation of CNS vasculitis. What are some of the imaging modalities we use? We'll go a little bit deeper into vessel wall MRI. We'll discuss some of the mimics of vasculitis and what are some of the pitfalls specifically in vessel wall imaging, and then we'll wrap things up after that. So initial investigation, why are we imaging these patients in the first place? Typically they have some sort of a new neurologic complaint. So they come into the emergency department maybe with concern for stroke, a headache, new vision complaints, memory problems, something like that. Alternatively, they may have been worked up and there's some strong clinical suspicion of CNS vasculitis, maybe based on the history and physical examination, the CSF and serum laboratory values or something like that. How is imaging going to help us? So what we can do is help demonstrate direct and indirect evidence of an inflammatory process affecting the intracranial arterial vasculature. So we're able to see clues on imaging that helps support the diagnosis of CNS vasculitis. So typically the first imaging modality that's performed on a patient presents with new symptoms is going to be a head CT. Done in an emergent or an urgent setting. It's a very good screening tool to look for hemorrhage, to look for an evolving acute infarct, mass effect and midline shift, things like that. You can also see things that you may want to further investigate with other imaging. So this is a CT here that actually shows areas of old infarctions of encephalomalacia or decreased density in the brain parenchyma. There's actually a patient who did have CNS vasculitis, one of their initial workups. So in addition to that, we can see also different types of white matter changes, maybe hemorrhage, things like that we want to investigate further. CTA, one of the first line imaging that's often done to evaluate the cerebral arterial vasculature. So CTA has a high spatial resolution. It's good for evaluating the larger size vessels, really, some of the medium vessels too in intracranial arterial vasculature. It has the benefit of being non-invasive. Alternatively, it does expose to some ionizing radiation. And then there are individuals who have severe allergic reactions to the iodinated contrast as well. So as an additional angiographic evaluation, this helps exclude etiologies such as large vessel occlusion, high-grade luminal narrowing, severe atherosclerotic plaque, dissection. In the setting of vasculitis, what you may see is multifocal areas of luminal contour irregularities, depending on the size of the vessel involved or the etiology, the origin of the vasculitis on the CTA, and some of the more distal, smaller vessels can be very difficult to sort of appreciate. Here's an example of a CTA sort of zoomed in the area of the circle of Willis. What the arrows are pointing out are areas of severe luminal stenosis in the para-ophthalmic ICAs. So you can see the larger vessels are very clearly outlined here on a CTA. It's a good initial tool to look for any abnormalities in luminal irregularity. I believe this patient had giant cell arteritis. MRI, one of the next imaging investigations that we do. So brain MRI has very high soft tissue contrast resolution. There's a benefit of no ionizing radiation exposure to the patient, although this is a little bit longer examination than a CT. So usually CT is performed first in the emergent setting. This can be a first line in patients with suspicious clinical history or laboratory values of CNS vasculitis, or it can be done to help further characterize something we saw on CT. So what it can show are some indirect findings of an inflammatory process. What do these include? So things like T2 and FLAIR hyperintense signals throughout the white matter, infarctions of varying ages in differing vascular territories. PO, leptomeningeal, and or parenchymal enhancement can be seen. and also areas of hemorrhage can be present on the brain. This is an example of a patient who has CNS vasculitis. So we have an axial flare image, we have an axial diffusion weighted sequence, which is sensitive to cytotoxic edema, showing us bright areas where there's areas of acute infarction. So the first image, we see two areas of bright signal on the flare. In the left frontal parietal area is an old infarct, and there's also a newer infarct on the left paramedian superior frontal gyrus. This patient had CNS vasculitis, was developing infarcts at differing ages. Another patient with CNS vasculitis, the top three images are flare images, very sensitive to white matter changes. The bottom three are diffusion weighted sequences, again, so be sensitive to evaluating people with acute infarction. So we're looking at the level of the centrum semiovalve, corner radiata, and the posterior fossa. You can see this patient has multifocal areas of white matter abnormality. Some of these are restricting diffusion. These are several different infarcts in different vascular territories, suspicious of an underlying inflammatory arterial process. And one more patient with some indirect findings on brain MRI. So this time we have a post-gadolinium sequence, the first two. Several areas of gyrofilarium enhancement are elucidated by the red arrows. So this develops the areas of revolving subacute infarct. Then we have very profound and confluent areas of flare hyperintensity insinuating throughout multiple vascular territories. And as we move on to the diffusion-weighted sequences, which are the last images here, we see that there are areas of acute infarction, areas of subacute infarction remote. The deep gray matter structures are involved. They're all bright, indicating that there's some infarction in those regions. The corpus callosum is involved, so very widespread involvement. These are some of the common indirect findings we can see. So MRA can commonly be performed with MRI. So that's one of its benefits. There's no ionizing radiation risk. So it's another way to look at the cerebral arterial vasculature, and no contrast is required. So we use a time-of-flight MRA, which takes advantage of the difference in the proton spins of flowing blood through vessels. We get different signal. We don't need to give contrast at all. Some of the drawbacks are that we could really only evaluate the proximal vasculature very well. Some of the more distal arteries we're not able to evaluate very well. And this is a sequence that's prone to artifact. So we're going to see a lot of artifacts on this. You know, sometimes we may want to get CTA anyways or a DSA to further evaluate something that we saw. Here's an example. These are 3D volumetric time-of-flight MRA images with maximum intensity projections in the top. So the first image is showing severe narrowing of the basilar artery. The second image is there's severe narrowing and near occlusion of the supraclinoid ICAs. The bottom two images are actually from vessel wall MRI, which we'll talk about more later. This show there's concentric enhancement at these areas of luminal narrowing, and this is suspicious of or supportive of vasculitis. Moving on to DSA. So DSA has very high spatial resolution. So this allows us to better resolve some of the distal medium and small size vessels much better than CTA or MRA could. Also has the benefit of getting flow or hemodynamic information. So the operator can injects contrast in real time and under fluoroscopic guidance can see how the contrast disseminates. Are there areas that are stenosed and there's decrease in transit? What is the venous drainage like? Is there early venous drainage and things like that? Has a drawback of being invasive. There is ionizing radiation exposure. So what can you see on DSA? Things like arterial occlusion, luminal beating, alternating areas of stenosis and dilation, segmental narrowing and stenoses. With DSA, there's a higher probability of your findings being related to vasculitis if multiple vessels and multiple territories are involved. And some of the mimics of vasculitis on DSA, intracranial atherosclerotic disease is a big one. Typically shorter segmental involvement with ICAD, more commonly eccentric luminal regularities as opposed to the concentricity in vasculitis. And RCVS is another one that can be indistinguishable from vasculitis in some cases on DSA. So this is cerebral vasoconstriction in multiple vascular territories, giving a beaded appearance in multiple areas of luminal narrowing, which can kind of confound things. Is it RCVS? Is it vasculitis? So two DSA images, two different patients with vasculitis. So we can see we have nice spatial resolution. These are very distal, very small vessels that we can identify areas of alternating stenoses and sort of a beaded appearance. These are probably very difficult to identify on CTA or MRA, so this DSA can really help us. Then moving on to vessel wall MRI, we'll talk about it a little bit more extensively. So in conventional angiographic studies, we're able to detect luminal narrowing or irregularity, but oftentimes unable to maybe understand why that luminal irregularity is there. So vessel wall MRI can help further investigate for any detectable vessel wall pathology at these sites of luminal irregularity. Also, it can help detect vessel wall changes or pathology before the lumen is affected. So in the setting of maybe a normal angiographic study, it may still show evidence of or supportive of the vasculitis. So briefly, some of the technical considerations for vessel wall MRI. So we need to achieve a high spatial resolution balanced with the signal to noise ratio to detect signal from these tiny vessel walls. So remember, we're trying to image very, very small structures and receive signal from them. So we're talking about some things as small as 1 to 2 millimeters in thickness in some of these arterial walls. Additionally, we need to get a 3D volumetric sequences when we form these wall sequences. This allows for multiplanar reformatting, viewing the vessels in multiple orthogonal planes. This can be very helpful to further characterize the degree of pathologic involvement. Is it concentric, is it eccentric, is it irregular? And also to help rule out if there's some sort of mimic or some sort of artifact, is there a vein traversing the vessel that we can only see in a different plane? The last thing that's very important is we need complete suppression of the signal from flowing intraluminal blood and the surrounding CSF. So the signal that we're seeing, we're sure is coming from the vessel wall. So how about vasculitis on vessel wall MRI? The classical description is uniform concentric vessel wall enhancement and thickening. Often longer segment involvement than in ICAD. So that's one of the big differentiating diagnoses that you want to make sure you're not falsely attributing vasculitis to interstitial atherosclerotic disease. So ICAD, usually eccentric thickening and enhancement. There is overlap, however, between these two entities. So you can see the concentricity with ICAD. You can see some eccentric vessel wall involvement with vasculitis. So it's very important to take into consideration the whole clinical picture and all the laboratory values when you're interpreting the imaging. So it's been shown that the enhancement of the infundibulum can be used as a strong internal standard, whether or not there's true vessel wall enhancement. So if you're sort of not sure, if you usually get pre and post contrast images, but if you identify enhancement in a vessel wall that's similar to the enhancement depicted in the infundibulum, that's been proven to be a strong internal standard to show there's true enhancement of the vessel wall. So here we have an example of someone with vasculitis. On the left is pre-contrast, and then after on the right is post-contrast. So we do have circumferential enhancement of this M2 segment. And you can see how important it is that we've suppressed the signal in the surrounding CSF and the flowing intraluminal blood. This is a relatively subtle finding that we've zoomed in on, but you can imagine if we had that signal present, we would maybe miss that or not be able to see that very well. Another patient who actually had suspected vasculitis secondary to a positive cryptococcal antigen. So you see there's robust enhancement in the left M2. Also in the right M1, there's circumferential wall enhancement and thickening. And in this instance, the MRA shows that there was preservation of the normal luminal contours at these areas of enhancement. So there was an inflammatory process going on we were able to detect without any changes in the lumen at that point. And then lastly, this is an axial vessel wall image following intravenous contrast administration. So we see areas of concentric enhancement and thickening of the vessel walls in the distal M1s and the proximal M2s. And this patient actually had positive Lyme antibodies, so plausibly an explanation for a secondary vascular process. So here we have 17 magnet MRI that we're starting to use for vessel wall imaging. This is really fantastic. We're getting wonderful images. We just started using them for clinical patients. So what's the difference between 7T and our conventional 1.5 or 3T that we may use? So a 7 Tesla strength magnet provides a higher signal to noise ratio. There's a higher contrast to noise ratio, and we can image with a much smaller voxel size. So all of this helps increase the detection and resolution of signal from very small pathology. So we can, better image, better identify any pathologic change in some of the more distal, medium, and small size vessels. So here's an example of a comparison of 3T and 7T vessel wall MRI. So on the left side, this is the same patient, and these images were performed not even maybe a week or so apart, a couple of weeks. On the first image, there is possibly very subtle enhancement in the small distal pericolossal artery branch. And on the 7T study, it's very obvious there's a very robust concentric enhancement in that same vessel, much easier to identify. You can see how the resolution is so much improved with the 7T magnet. Again, with the same patient. So this time in the sagittal plane, we show that same vessel. There's diffuse, long segmental circumferential involvement, enhancement, and thickening of that vessel wall. And then going back to some of the indirect findings we looked at earlier, this is the same patient where their new acute infarct was in the same distribution of that small artery. And here is an example of 3T and 7T. So what we had before is a pre and post contrast on a 3 Tesla with the left M1 segment showing circumferential enhancement, very classic for vasculitis. After follow-up, after treatment, they did a 7 Tesla magnet study with the same protocol, and there's no discernible residual enhancement in the area that was previously enhancing. So we would probably be able to detect even subtle enhancement on the 7T because of the much better resolution. And then we'll touch on some mimics and pitfalls. So mimics of vasculitis and mostly pitfalls of vessel wall MRI to be aware of when interpreting these images. The first one, intracerebral atherosclerotic disease, we'll talk about again, because we commonly see this. So again, eccentric and often irregular vessel wall thickening and enhancement. These vessels can undergo wall remodeling, both positive and negative wall remodeling. Some of the other constituents of plaque better demonstrated in vessel wall imaging of the extracranial arterial vasculature, just because it's usually bigger and we were able to see a lot more signal from it, include T2 hyperintensity of the fibrous cap, and also the hypointense plaque on the T2 weighted pulse sequence. So if you have T1 hyperintensity intrinsic to the plaque, this is suggestive of intraplaque hemorrhage. Again, difficult to identify in sort of the very small intracranial vessels, but this is indicative of an unstable plaque. These atherosclerotic plaques are commonly at vessel branch points in the MCA, distal ICAs, the vertebral arteries, and basilar artery. And then plaque rupture is the complication of FEARD, so exposing the necrotic thrombogenic core, contributing to luminal narrowing, giving off emboli or small branch origin occlusions. So this is a really nice, this is 17 magnet. We did a vessel wall MRI with MRA. On the left, I'm pointing out that there's very severe narrowing of the basilar artery. And on the post-contrast vessel wall study, we see that there's a large eccentric enhancing plaque right at the area of stenosis, so we identify the etiology of that narrowing. Another patient who was relatively younger, but I think had a family history of Moyamoya type syndrome, had a lot of increased atherosclerotic risk factors for younger patients, somewhere in their 40s. There's really dense enhancement of the left M1 with commensurate significant reduction in caliber of the lumen with the left M1 and the MRA. So this patient was thought to have an isolated area of atherosclerotic plaque based on the clinical picture and the imaging put together. You can see our 7 Tesla really elucidates that very nicely in these images. And then finally, another patient who was middle-aged with multiple risk factors for atherosclerotic disease. So I'm showing here 7 Tesla vessel wall imaging, both in the axial, the sagittal, and coronal plane of the same area of enhancement that's sort of eccentric and irregular in the left ICA terminus and proximal left M1. So you can see it in all 3 of these planes, and also on the MRA, there's an area of severe narrowing corresponding to that. This is a nice appearance of atherosclerotic plaque and 7T vessel wall MRI. So another very common mimic that needs to be differentiated from vasculitis is RCVS. So RCVS, what is it? It results in arterial wall thickening, but the vessel wall is almost always non-enhancing. So it's one of the big differentiating factors. What's happening is there's a transient disturbance in the cerebrovascular tone. The smooth muscle cells shorten in length and with increased overlap amongst the cells. So we're looking at oftentimes up to 500% increase in wall thickness, up to 60% increase in luminal narrowing and RCVS in multiple vascular territories. So the differentiation between RCVS and vasculitis is important because of the clinical implications in treatment. RCVS is treated with calcium channel blockers, sometimes just observation, average of reversible time, about 3 months, whereas vasculitis, steroids, immunosuppressive therapy, median time to improvement depending on the intervention and what pharmacologic agents, things like that, much longer than RCVS. So this is a young patient presented with thunderclap headache. The first image is a CTA with maximum intensity projection. There are several areas of luminal narrowing in the anterior circulation, the ACAs and the MCAs. And on subsequent exam, this was 6 weeks later, they did an MRA, and it shows that all of these areas of luminal narrowing had resolved in the interim, suggesting RCVS. Another patient with multifocal areas of luminal narrowing, so this is a 7 Tesla study. The MRA shows severe narrowing. Vessel wall imaging was performed with no discernible enhancement that you would suspect maybe with vasculitis, so again, suggestive of RCVS. Vasa vasorum enhancement can be misinterpreted as pathologic enhancement. So this is a tiny microstructure that supplies nutrients to the outer components of veins and arteries, more so in the veins because of the increased deoxyhemoglobin content. So there's a relative lack of vasa vasorum around the intracranial arterial vessels normally. In fact, they don't exist at birth. It's thought that the CSF nourishes or gives the nutrients to the vessel walls. So with increasing age and increasing atherosclerotic risk factors, you can develop vasa vasorum around the intracranial arteries. What it looks like is mild enhancement, often circumferential, of both the ICAs and the intradural vertebral arteries near the sites of dural penetration, thought to be an extension or proliferation of the extracranial vasa vasorum. So 2 examples of this. So coronal vessel wall, 3T, shows areas of circumferential enhancement of the proximal V4 segments. And another patient in the axial plane, similar concentric enhancement. This is a very common place for vasa vasorum enhancement, should not be misinterpreted as something pathologic. Flow-related artifacts can also be misleading, and because of the laminar parabolic nature of flow, intraluminal blood flow is usually slower, closer to the periphery. This causes incomplete signal suppression related to locally reduced peripheral flow, and this can mimic vessel wall thickening enhancement, so something to be aware of. This is a coronal image and a vessel wall image of the patient. The arrow points out an area of increased signal intensity, so it's curious, is this enhancement, is this some true pathology? The MRA in the same exact region of this cavernous ICA is widely patent, so this was a flow-related artifact from incomplete signal suppression. Changes after mechanical thrombectomy can look a little bit unusual, and maybe this is suspicious of some inflammatory process, but it's something to be aware of. Different devices are utilized for thrombectomy. So most commonly stent retrievers, thrombosuction devices. What happens is with the stent retriever, you can cause mechanical shear stress. With the suction devices, you can create negative pressure, damaging the vessel wall. So all of this leads to endothelial damage, vessel wall edema, and even can cause increased inflammation in pre-existing plaque. What you can see with this is concentric enhancement at the areas of recent mechanical intervention. So this is an example of someone who had an acute occlusion on the CTA of the right distal M1, a thromboembolic occlusion. They underwent mechanical thrombectomy, had vessel wall imaging very shortly after the intervention, which showed an area of concentric enhancement at the site of intervention, which subsequently resolved. And then this is one more example of a different but more rare intracranial pathology. So this is a 7 Tesla magnet. These are images from the MRA and the vessel wall imaging following contrast administration. So what I'm pointing out here is an area of severe narrowing in the right M1. There's some sort of unusual, irregular enhancement in that region. If you look at the vessel and foss, and this is another reason we get these volumetric sequences, so we can manipulate the vessel and look at them in different planes. You'll see that there's a small dissection flap that's enhancing. So this was an intracranial arterial dissection, which is a more rare finding. But you can see how we need to sort of further investigate any sort of enhancement and try to understand if it's some sort of a mimic or if there's some kind of inflammatory process going on with the vessel walls. So wrapping things up, we have a lot of imaging available to help us. It's supportive of the diagnosis of vasculitis, but not essentially diagnostic for a vascular process. So we use it in conjunction with the clinical history and all different labs that have been obtained. Conventional angiographic studies, CTA, DSA, MRA, these are only used to evaluate luminal contour irregularities. CTA has high spatial resolution for larger vessel evaluation. DSA is invasive, but more sensitive for the small and the medium-sized vessels, as we discussed. MRA with MRI can depict both the parenchymal and the luminal changes, so we're able to look at both the indirect and the direct findings that may be supportive of vasculitis. Luminal irregularity on the conventional angiography can be further evaluated with the vessel wall MRI. And it's important to be aware of some of these pitfalls and different mimics when you're interpreting the vessel wall MRI, and also take into consideration all of the clinical picture in conjunction with what you're seeing on imaging when evaluating these. Thank you.